You are listening to Medscape's In Discussion series on psoriasis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Stephen R. Feldman, editor of the Journal of Dermatological Treatment and professor of dermatology at the Wake Forest University School of Medicine in Winston-Salem, North Carolina. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for healthcare professionals.
Hello, I'm Dr. Steve Feldman. Welcome to Medscape's In Discussion series on psoriasis. This is our first episode of season 3. Today, we'll discuss insurance and access to care. These are a couple of the most important, serious, and pressing issues in psoriasis management. We have a remarkable guest today who's been at the forefront of these critical issues. He's a board-certified dermatologist in Philadelphia, a clinical associate professor in the Lewis Katz School of Medicine at Temple University Department of Dermatology. He formerly was on the faculty of what I believe may be the absolute top dermatology and health economics programs in the country at the University of Pennsylvania. Our guest today is a passionate advocate for equitable access to healthcare, particularly for the underserved and vulnerable populations. In publications from JAMA Dermatology to the New York Times, our guest has raised awareness of the disparities that exist in healthcare delivery, the high costs of prescription drugs, and the barriers posed by insurance policies. He's well known for his innovative work on telemedicine, showing how technology can be a powerful tool to bridge the gap for patients in rural and underserved areas. It's my great pleasure to welcome Dr. Jules Lipoff. Jules, welcome to In Discussion.
Well, thank you for the invitation. It's really an honor and a privilege to be invited, and I look forward to talking to you today.
Jules, before we get into the nitty gritty of healthcare finance, I want to talk to you about something maybe even more important. Look, I got a chemistry background. I loved organic chemistry because you only needed to know one or two principles of what electrons want to do, and you could predict all of the resultant chemistries. It's so powerful, just two principles. You have a background in chemistry and biochemistry too, but you also have this amazing background in comedy, of all things. I'm thinking there must be a principle or two of comedy that may apply to how we can or should interact with our patients. Tell us a little about your work in comedy and your thoughts about how it informs your work with patients.
Well, I think comedy is really a good study of human interaction, and also it's about accepting rejection and failures. So, for instance, when I took improv comedy classes at the Upright Citizens Brigade in New York, they in long form improv comedy they have this motto, which is yes and, which is when someone says something or creates a new reality in a scene, you don't quibble with it, you don't debate what it is or what isn't. You accept what has been done and then you just build off of it, right? Failure actually can pave the way to success, but you can't mire in it. You can't be frustrated. You can't get into arguments. You just are forward thinking and always trying to build and move forward.
Yeah, I love that. I think of that when I'm taking care of delusions of parasitosis patients and they say something I totally disagree with. And instead of arguing with them, I go, yes, and we're going to put you on this antipsychotic.
Yeah, I mean, it is really about like in that particular situation, you could get really mired in the weeds and you're never going to talk someone out of a fixed illusion. So why don't we just focus on what is actually going to make progress? It's like this medication may metaphorically get rid of your bugs.
Yes, I just don't use the word metaphorically in that sentence with them. All right. So let's move to telemedicine because interacting with patients in person is one thing, but it strikes me that telemedicine may be a different beast altogether. Do you think it's a different skill set?
Certainly, I think you have to be a certain tech savvy to be able to make it work. I mean, just even the like self IT help aspect of it, setting it up, being like if one program doesn't work, being able to communicate, connect to someone, have a backup, all this sort of thing. But also, dermatology is so physical exam focused, right? I mean, sometimes I hear people say, usually it's the H and P in medicine. Really, dermatology is the P and H because the physical is so forward, right? But in telemedicine, there's barely a physical exam. It's mostly focused on things like a cursory glance. You can basically say what something is, and then mostly it's an intellectual cerebral exercise and communication. I mean, you're I think less likely to pick up on certain nonverbal cues, right? Like you can't really you can see their face maybe, assuming it's a live video telemedicine interaction, but you can't necessarily get the whole picture. How you don't necessarily see them walk into the room. You don't necessarily see how they're acting with staff and other people, right? You might not pick up on all of that. On the other hand, you get the benefit of like you see maybe the room they're in, maybe you see their workplace, maybe you see that they're doing this telemedicine visit on a bus or because they're a cashier at a convenience store and they're trying to like check people out in the middle of your visit. Like some of that's really interesting to get a true glimpse into their world. So that's also useful, but it's different. So for instance, we sometimes make the comment we see certain skin cancers more on the left side of someone, but when you see a fire department person or a police officer sitting in their car, or an electrician, I think it was sitting in their car as they're doing their visit, and I'm like, I think you're getting it on this side of your body because look, it's hitting you right there. Right. So that hit a little harder than if this conversation had been in the room.
I've noticed that true glimpse into their world before, but I don't think I really fully appreciate it, put into words as you just have how cool that is. You're basically doing a home visit in a sense. I find telemedicine to be wonderful for psoriasis patients, especially for following up on their biologic treatment, because really don't have to see very much. They're clear. They save so much travel time coming to see me, so much waiting time from my office. I think they just love the telemedicine visits. And I love making patients happy. But at the same time, trade-offs, I find telemedicine horribly inefficient. And with no procedures ever with telemedicine, it seems like it turns a well paid dermatologist into something very much more like a poorly compensated primary care provider. Am I missing something?
You're thinking of telemedicine only through the lens of live video visits, whereas there are a lot of different types of visits. Now, during the pandemic, the focus with the way reimbursement was structured and the loosening of HIPAA and everything really geared towards live video. But there's also different types of models. It's not just one flavor. There's also store and forward models, which unfortunately are not well reimbursed still, but they would allow you to answer at your own leisure without a scheduled appointment time with the clinical information and photos, and you wouldn't have, like, say, a long extended conversation with a patient that isn't necessary. It could be a lot more transactional and move through cases very quickly, possibly a minute per case or something like that if you're really efficient. And that would allow you to help a lot of people very quickly. I mean, to your point, we need to make sure that this is at least cost neutral, right? No one would be losing money by this way. Maybe they wouldn't gain more money by doing more telemedicine. But I think if you design a system of triage in the right way, for instance, I put all of my Accutane and acne follow up visits into these visits, and those rarely would have had procedures anyway, and they can be a lot more efficient, especially if you have a bunch of Accutane visits back to back. We're keyed up to check on pregnancy tests, labs, and refill things very quickly. Me and the staff who are taking care of these visits. And then also, you're set up to triage to get people in for the procedures. You don't have to waste a lot of time. You can say, this is a pigmented lesion I can't adequately assess. You should have a full skin check anyway. That looks like a cyst. That would require a visit. You're triaging it so that your in person visits are actually going to be more highly proceduralized. So it would even out.
I love that. Are there any other insurance factors I need to be thinking about with respect to telemedicine?
I think it's still an evolving landscape. Not every state has parity laws that guarantees that you get paid the same video as in person. I do think that there's an assumption that telemedicine cannot be as good. I think as a gold standard, we do want when you evaluate physical exam of a person, I think yes, in person is generally better, but you have to think about the whole person. For instance, when I had like a 70-year-old woman with powderma gangrenosum on her leg that would have to drive an hour away both ways, and it was really just a wound check, it was not necessarily the patient's best interest to go all that distance unless I felt it was necessary, right? We could put them at not only the time, but other risks. The goal is excellent patient care, and we should use whatever tools and methods we have at our disposal to achieve that, whatever is the most appropriate. Now, I wouldn't want an insurance company to say, seeing that telemedicine costs them less, for instance, to require you to have a telemedicine triage visit first. I think everyone should always have the right and the ability to be seen in person if they want to be seen in person. But I do think there are situations that lend themselves better to telemedicine than in person and the other way around.
These insurance issues must factor into other aspects of psoriasis care. Is cost a common issue for patients filling, or should I say, not filling their prescriptions?
Well, definitely cost is an issue. I'm sure you've heard about this all the time. I mean, I also know you've written on related topics yourself, but we published a paper in JAMA Dermatology a few years ago. I think you may have actually written a reply to it about reasons that people are not filling their acne prescriptions, and the copays were a significant reason why they were not filling. I mean, unexpected copays are a big reason, prior authorizations and all of this. I mean, certainly there are side effects and other concerns that hold people from filling their prescriptions, but definitely cost. I mean, the the burden on this healthcare system of biologics and other new medications is incredible. They're just ridiculously expensive, and we're stuck in a situation, ethically, of weighing what is appropriate for our individual person in front of us versus which is better for the financial health of our entire population. And that's really quite impossible to figure out. In general, I think we do the best we can with the tools we have for the patient that's in front of us, but it may not be sustainable if we keep spending money recklessly.
Yeah, I think in settings like this, it's great. And we tend to focus a lot in settings like this on the societal aspects. But when I'm sitting there with a patient in front of me, you praised it perfectly. We do the best we can with the tools we have for that patient. I don't really worry about society at all when when I've got that patient in front of me, because I just got to do what you can for them. How else can we help patients with regard to cost?
Well, I think we can help cost in a lot of ways. It's interesting when if something is really much more effective and is much more expensive, I think it's something that we can maybe justify. But there are a lot of things that are more expensive that aren't necessarily better, right? Like a topical lacquer for onychomycosis, not very effective, but very expensive, right? So that might be inappropriate to, I mean, generally speaking, I think fixed vapor rub is just as good as a finiconazole. I don't know that it's appropriate to do the more expensive thing. But beyond making smart choices about what will be efficacious, will be getting your best bang for the buck, I think you can think about where you filled prescriptions and how you send them. I've done particular focus on, say, medications for androgenic alopecia and how we fill them. There's a lot of quirks, for instance, around finasteride about how it's prescribed. So for many years, I would have patients split 5 milligram tablets and quarters instead of taking a 1 milligram because of how much more expensive the 1 milligram was. And now I'm more aware of different options for filling prescriptions that Costco, a discount pharmacy, which does not even require membership to use their pharmacy, a fact that most patients don't know, you can get a year's supply of finasteride for like $50, whereas it might be 25 a month from your local pharmacy. So just being aware of little shortcuts. I might even go so far as to argue that we're so focused on efficacy and safety in our patients, but we don't really value cost. But I think cost does impact the safety of our patients. A lot of our patients are on fixed incomes or have limited budgets. If they're spending more money on one thing, it's got to come from somewhere else. And so we really got to be respectful of that and realize that when we suggest something that might be expensive, uh, patients may not feel like it's optional and they may feel that it's necessary. I'm sure some of us have had patients who have filled medications that we thought, oh, maybe it'll work. And then it costs 200 out of pocket. We didn't realize it. And then we feel terrible that they spent that money. Make sure that they know that there are alternatives or they know to call if something is going to be unexpectedly expensive.
Yeah, I remember when oral terbinafine used to be over $1,000 for a course of therapy, and then Costco had it for $10 for a prescription. It was amazing. I've begun to proactively use goodrx.com to try to identify costs proactively when I think it's going to be an issue. Is that a good resource? Are there other platforms I should be thinking about?
So I do think GoodRx is worthy of some real serious discussion. We just published an article in JAMA Dermatology about prescription cost saving platforms, and GoodRx is definitely the best known of them. I think I've used it a lot. I've had a lot of success saving patients money with it, and it's been very useful. But it's not a cure-all, it's not panacea, GoodRx has some issues, they have been accused of mishandling patient data, and they actually settled a case with the Federal Trade Commission. They've also reportedly shared personal prescription data with third parties for advertising and analytics. It's important to the extent that we can be aware or be transparent with patients that it's not perfect. It's not necessarily whatever you give to GoodRx, it's not protected by HIPAA, for instance. There are other things developing in this area. For instance, Mark Cuban cost plus drugs, which is also interesting. So GoodRx is basically pretending to be insurance to help negotiate prices with pharmacies down. Cost plus drugs is directly manufacturing and shipping out drugs, and they're transparently marking up 15% of their cost for their revenue. They have a more limited selection of things, and we have yet to see what the issues may be in the long term. But it does seem like that is an interesting model to explore. There's a lot of markup on a lot of medications, and companies taking money from all sorts of the different interactions here. I think we just need to be aware of the cost, be as transparent as possible. And my hope is that maybe with AI and other tools, we'll be able to better predict and direct patients to save money when they're trying to fill medications.
All right. Well, as we start to close, are there any other access to care issues you want to leave our listeners with?
I do think that in dermatology, we have a real issue with access to care. We have a bad reputation for how difficult it is to get in, but also there are a lot of patients who can't get in. Our specialty is not have the best reputation for accepting government assistance patients, Medicaid. There's a lot of need there. I mean, makes sense financially. There's no incentive to do that. And there's no incentive for someone to start taking Medicaid if they're going to be the only game in town taking it and then they get flooded with it. But I would like to find ways to make it mutually beneficial for everyone to help the most people. It's frustrating that the people that often need the most help make you the least money. And it it would be better for everyone for that to be a little more aligned. I, for instance, have a active grant program I'm working with a federally qualified health center. We're using telemedicine to support patients living with HIV and LGBT communities. We are doing telemedicine to support these communities, but also we're trying to pair with fairly qualified health centers. They actually get enhanced reimbursements, pretty competitive reimbursements because they're government supported. And maybe if there's a way to pair subspecialists with them, for instance, if it's part of a primary care visit they're doing, they can get a competitive reimbursement and then separately subcontract with a decent rate, a subspecialist to support that care, perhaps by telemedicine. So I think there are innovative models that can make it financially sustainable while also supporting the people who need it most.
Jules, thank you. Today, we've had Dr. Jules Lipoff discussing insurance and access to care in the treatment of psoriasis. You can learn more about Jules and his work at www.juleslipoff.com. That's JULESLIPOFF.com. Some of the key points we covered included telemedicine, in particular, its use to help patients get access to treatment. Access to treatment in terms of cost is another thing we discussed in the alternative pharmacies and pharmacy information systems we now have online may help us with that. I think Jules makes the most beautiful point that people who need the most help may be the least financially remunerative patients to care for. Fortunately, I'm basically on a straight salary, which lets me take care of the folks I need to take care of. Thank you so much for joining us. I hope you'll join us next time when we discuss obesity care and psoriasis with Dr. Robert Kushner. This is Dr. Steve Feldman for In Discussion.
Thanks for listening to Medscape's In Discussion Psoriasis podcast series with our host, Dr. Stephen R. Feldman. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on psoriasis.